of the key presentations made during this ESMO 2016 are on non-metastatic colorectal disease. One is on surgery of rectal cancer, the other one is on surveillance of patients after the surgery for colon cancer. Currently we have a different surveillance program all over the world. It's not the same in the US, UK, Germany, France or what else, or in Asia. This trial randomized 1,200 patients with 4 groups of 300 patients with no surveillance at all, carcinoma embryonic antigen dosage, CT scans or both carcinoma embryonic antigen and CT scan. 300 patients per group, and they followed the patient. What was seen is that globally the survival are the same in all the group, which is normal, but in the patient that present a recurrence of the disease, more patients were eligible for a curative treatment in the 2 groups with CT scan, so the 2 intensive group of surveillance. So surveillance is now mandatory for this patient with at least a CT scan every 6 months, to my opinion. The second topic was on rectal cancer. Rectal cancer is a problem because of a huge recurrence rate locally, so we do radiotherapy or radiochemotherapy before surgery. We've seen previously from retrospective data that when waiting longer after radiochemotherapy for surgery, the tumor shrinkage was better and the PCR, so the pathological complete response rate, increased, which may be a good option for the patient. So this trial randomized 6 versus 12 weeks after radiotherapy for surgery to see if to wait longer is better for the patient. The conclusion of the trial is that MRI images are better after 12 than 6 weeks, that pathological response is better at 12 weeks as compared to 6 weeks, and that probably is good to wait 12 weeks. The problem is that there is a controversy on that topic because recently a French team published a GCO showing exactly the contrary, that waiting too long is not necessary, that you do not gain a lot of pathological complete response, and that you increase the complication rates during the surgery by waiting too long. So probably that 12 weeks is too much, that 6 weeks is too early, and that to operate the patient at 8 weeks will be the good ratio for the patient benefit and risk.
Any medical oncologist who has some years of experience in treating metastatic colorectal cancer knew that the right side tumors are not doing as well as the left side, but we didn't have really numbers, so I suggested ESMO to look at all the big studies that were performed in the past 10 years or so, for which all RAS was available and for which the side of the tumor was also available. So we started with 6 big trials, a total of almost 6,000 patients. Of course, we removed any RAS mutant and all the patients for which the location was not known. And we looked from the prognostic point of view and to the predictive point of view, and this confirmed the initial impression that right side was of poor prognosis compared to left side, but we added to that the predictive value of the use of anti-EGFR monoclonal antibodies, and the outcome was totally different in terms of response rate, progression-free survival, and overall survival, in which the use of anti-EGFR were really favorable for the left side tumor, but were not on the right side, with even maybe a slight trend into a detrimental effect as compared to chemo alone or chemo bevacizumab. It seems to me clear now that there is no doubt on the benefit added by anti-EGFR for left side colon cancer and the absence of benefit on the right side.
This ESMO, we have learned a lot about new medical treatment options in hepatocellular carcinoma. This was really a main topic. Hepatocellular carcinoma was a difficult field concerning medical treatment. We had sorafenib for the advanced stages, but nothing else. And we have seen 1 decade of negative studies. And now finally, there are new options coming into the field. And one option has been presented here. I'm talking about the RESORCE trial. which randomized patients who failed on sorafenib to receive regorafenib, a multityrosine kinase inhibitor, or placebo. This study showed a positive result in terms of overall survival, which was the primary endpoint. Patients who received regorafenib had a median survival of 10.6 months compared to patients who received placebo, who had a median survival of 7.9 months, and this is a significant difference. Beyond that, we also see other new emerging options, and immunotherapy may also play a role. We have seen a big non-randomized phase 2 study putting patients on nivolumab, which is a PD-1 inhibitor, and these patients came from different etiologies of hepatocellular carcinoma, infected with hepatitis B or hepatitis C, but also non-infected patients. And what we see is that there is an interesting response rate of around 16%, which is definitely more than what we can achieve with traditional options like sorafenib. And what also matters is the duration of response, which looks quite attractive. So at the horizon, I would say, there is a new treatment option for patients with hepatocellular carcinoma, which goes probably into immunotherapy. In esophagogastric cancer, we have learned from a big French study that it's really worthwhile for patients, regardless of their comorbidity, to go to high-volume centers to get their esophagectomies or gastrectomies.